It's my pleasure today to introduce our speaker, Arjun Yodh from the University of Pennsylvania, where he's the chair of the department, and I had to look up his title. It's the James Skinner Professor, not of physics, but of science, much broader. And let's see, some random facts about Arjun. His father was Alan Mintzer's thesis advisor.
I did not know that it was the same Yodh.
Yes.
His father is a phenomenal.
So there's that connection. Arjun's one of the few people that I remember when I met him, because I gave the first colloquium at the University of Pennsylvania in the fall of 1988, where he was a new assistant professor. And after I gave my talk, by the time I got to talk to him in his office, he already had an idea for how we could collaborate together. He had a really nice idea for an experiment, so we started working together. And we had papers that spanned about seven or 8 year period together. So that was very nice. Since then, he's been involved in a number of things. He's known for the development of diffuse light scattering probes of people, ways to detect breast tumors and to interrogate the brain for things like hemorrhages and so forth. So he's very well known in that area, and that's sort of related to some of the things he'll talk about today. He's done a lot of work in nanorods, and in particular figuring out how to suspend them in liquids in a nice way. A lot of work on something called the depletion interaction and elucidating how it works and what you can do with it. And generally covering just a broad range of soft matter science. He was a director of the LSRM, which is the materials lab at Penn, and was director of their MRSEC for, I don't know, 2 or 3 cycles. So he's had a big impact on materials research at Penn. Now, before we say any more else, maybe Glenn has a few things to say.
Well, I think I want to stand up to say it. Which is that all of you have Arjun to thank for CSMR. And the way that is that at an amazing random event, both of us were returning from Geneva. We did not know one another. I had been at CERN for a month or 2 in the spring of '98, and we were sitting next to each other on this airplane. And one of the other of us, I don't remember who, was reading Science magazine. And the other said to them, "Oh, what do you do?" And so we started chatting, and at that point I had been asked to come and refurbish the physics department, and I was going to be talking. It's a long story. I could go into it privately, but anyway, what was on my mind is I thought what it would be the right thing to do is to jump over a lot of other departments who had really strong this and that, and pick areas that were going to bloom in the future. And one thing that was obvious to me was the union of particle physics and cosmology, but that's too theory. That's great. It's inspires students, maybe donors, so on, I hope.
It's still good.
Yeah, that's right, that's right. But I thought it should be balanced by something that would have a more laboratory and more, really it's complementary, but also shouldn't be something that all the big shots were doing. And Arjun, as we spoke, explained to me that soft matter was the thing.
That's true. I forgot about this.
Yeah.
I mean, I didn't forget about
Anyway,
this.
so, and, this is, you were right.
Thank you, Arjun.
They're pretty good.
That was a nice long flight, and it was good. Okay, so oh, weird. All right. Ooh. Okay. So thanks, Paul, for the invitation to come to NYU. It's always fun to come here. It's a great department. I have many friends. What I want to do, I'm going to kind of give a overview / progress report about what we've been doing for a long time now, using light, diffusing light to look at tissues. And I wanted to start, with this paper, which Dave sort of was talking about when he gave his seminar. Just because I think you can trace back everything I'm going to talk about to this paper. For me, personally, I mean, there's all sorts of other connections, but for me personally, so I can thank, Paul and Dave for this. Okay. All right. So I'm going to tell you a lot of things. I'm going to try to put people who did the work on the slides, but I have a lot of people who did the work. And the folks at the top right now are really collaborating in my group, and especially I want to mention Wes Baker, who's an assistant professor at CHOP, which is Children's Hospital of Philadelphia, and Tiffany Coe, Rodrigo Forti, and Joe Majeski, who are all postdocs or researchers. And then you'll see that there's a lot of stuff, we're trying to push it into the clinic. So you can't do that without a lot of collaborators and for me, it's mainly from the Hospital of the University of Philadelphia or the Children's Hospital of Philadelphia, the University of Pennsylvania or the Children's Hospital of Philadelphia. And so I have a group of folks that have been interacting me mostly with the brain. They're here. I'll show you, and John Detra and Joel Greenberg really for a long time. And then for cancer, I'm going to just show a tiny bit about it. But again, you need to really have doctors that have a vision that they want to try new things. And so it's really important that these folks, and again, with Brian and Mitch and Mark and Angie. Okay, so the plan then is I'll just kind of give a very general comments about diffuse optics. And then I thought I would spend some time talking about how you make the measurements and what are the metrics that you can get as a result. And then depending on the time, I'll cover some of this or a little of it. I wanted to talk a little bit about breast cancer, what we've done. My primary focus now is about the brain. So I'll show a couple things about that. And then we had one kind of thing I'm proud of recently about the placenta, which I may say something about. And you should interrupt me, by the way. Okay. Okay, so essentially the goal of diffuse optics is to look at, in tissues, right, is to look at chunks of tissues, millimeter to centimeter chunks with light. And, that's hard to do if you want to go below the surface. But if you look at the main absorbers in tissue, and so on the right is just the absorption versus wavelength for a couple of those absorbers. There's a window in the near infrared where the absorption is fairly low, okay? So that's oxy and deoxyhemoglobin and water. There's also, you could put lipid there, it's sort of like water. And so at least if you're willing to work in the near infrared, at least your light won't get just absorbed, okay? And so if you could do this, then in principle, do this non-invasive biopsy if you like. You have this sort of tool that's portable. You can use it at the bedside continuously. It's relatively inexpensive. It's really just near infrared, low power radiation is not dangerous. And it also has some different kinds of contrast than other technologies. And I'll say a little bit about that. You can ask me about that if you want also. So, there's a lot of attractive things if you're willing to, try to use the near infrared, but it's hard. And the reason that it's hard is because of scattering, okay? And so this is just, again, for some people this is going to be super review, but sorry about that. So this is sort of looking down on a sample with water or a little bit of milk in it, and just looking, I'm shining a laser through it and looking at 90 degrees. So, the water, the light goes to the straight line. If I have a little bit of milk, it mostly goes to the straight line. But if I have a lot of milk, which is like what tissue is, that's what it looks like. It's really scattering like crazy. And so that's the challenge, okay? But it turns out that in this limit, this isn't true for every tissue, but for lots of tissue. In this limit, basically, and working in the near infrared, the absorption's fairly low, okay? So you might have absorption lengths of about 10 centimeters or 5 centimeters, depending on the amount of blood. But the scattering is short, and so the random walk step for the scattering might be about 1 millimeter, okay? And so, to a very good approximation, in this limit, the light diffuses, okay? So we can think of it as doing a random walk as it goes through the tissue. And so, the main thing is that if you're willing to sort of give up the wave equation to analyze your data and just use the diffusion equation, then you can make a lot of progress. And you can probe literally chunks of tissue located centimeters below the surface, and I'll show you some of that. Okay, so, and if you're willing to do that, you can measure useful things, and I'll show you how this comes about. But you can look at the blood oxygenation, you can look at the blood total concentration, you can look at the blood flow, you can learn about the tissue oxygen metabolism, you can learn about autoregulation, and if you can measure these things, there are good physiological targets which have value, such as the brain, such as cancer, such as looking at muscle, looking at peripheral arterial disease, looking at the placenta, lots of things. Where if you can measure these things with fidelity, that can help in treatment. So, how do we do that? Okay, so what do I want to show here? So, first of all, generally there's 2 different experimental geometries we would use. One is in transmission, and one is in reflection, okay? And so, so when we do breast imaging, for example, it'll be in transmission, and it could be through 6 to 10 centimeters of tissue, okay? So, that it's penetrating through that, you're looking at tissue pretty deep, right, below the surface. If you do an experiment in the reflection geometry, which is the case for most of the measurements on the head, then, basically, you still are, your penetration is set roughly by the separation between the source and detector, about maybe 1/2 to 1/3 of that, but it's a broad set of pathways for photons. So basically, then that's still good enough, for example, to look at the cortex. Okay, you have a finite amount of light that you can put in due to the FDA, and so if you want to look at some of the things we're looking at, you want to at least be 2.5 to 3 centimeters. Okay. Okay, so anyway, so that's the geometry, and then this diffusion, the underlying equation that I told you we would use instead of the wave equation is the diffusion equation. Again, many people I'm sure are super familiar with this, but basically you can think of phi as the light fluence rate as kind of like the photon concentration. The absorption, that's that mu A, that factor that I talked about in the first slide. And that's what's going to give us sensitivity to different chromophores in the tissue. The D is the light diffusion constant. So that depends on the random walk step, where this US prime is the scattering. Okay? So the kinds of measurements, okay, so I'm going to talk about different kinds of measurements, but the simplest one is just, so I'm calling that the standard one here, is just, shining light in and just detecting it over here, nothing special really. So the simplest one is if you have continuous wave light, so then you just shine in light at the constant intensity, measure it, constant intensity some distance away. That's actually, almost all the commercial devices do this, okay? But there's a major weakness. It doesn't separate the scattering from the absorption for this kind of measurement. Sort of a little bit more sophisticated one is to modulate the light, let's say 100 megahertz or 200 megahertz. And then, you can measure over here that it'll still be some oscillating signal, the diffusive wave, but basically the amplitude will be different and the phase will be shifted. And then sort of the Fourier transform of that is like if you put in a pulse and you measure the broadening, okay? So these other 2 methods are much better because they enable you to separate the scattering from the absorption, okay? So if you can separate the scattering from the absorption, and I should say, just for simplicity and this is certainly what happens almost always in the beginning. Just imagine the brain or the breast as a homogeneous medium, okay? And so then you can basically solve the diffusion equation for the homogeneous medium if you're getting the average property, say. And you can, by fitting to it, using your source detector data, different source detector separations of the phase and the amplitude. For example, you can figure out what's the absorption and what's the scattering, okay? Okay, so then what you've gained at the end is that you can separate the scattering from the absorption. And so you can measure the absorption. Now the scattering is also useful, potentially useful diagnostic, but the absorption really is useful, okay? And the reason it's useful is because we can do spectroscopy, okay? And so here's sort of a blow up of the spectra in the near infrared of, again, oxy and deoxyhemoglobin and water. And so the big absorber and the big one that we care about, actually we care about all of these, but the workhorse is the oxy and the deoxyhemoglobin. And basically, if you make measurements, then for example, just for concreteness, if you made measurements at 2 wavelengths, okay, then, you know, you've separated the scattering from the absorption, and you have the absorption at 2 different wavelengths. Now we know what the extinction coefficients are for the oxy and deoxyhemoglobin versus wavelength. But we don't know the concentrations. But still, like, this is just 2 equations and 2 unknowns that you can solve and get the concentrations. So I can get what the total hemoglobin concentration is. And I can get what the tissue oxygen saturation is, which is sort of the fraction of oxygenated hemoglobin divided by the total, okay? And I should say that a lot of times people use, and I use, tissue oxygen extraction fraction. It's like 1 minus that, 1 minus saturation. I just wanted to say that because there'll be plots that may have OEF. Okay, but basically it's equivalent. So, so this is good. So, and you know, that's, when I started, mainly that was what we were doing. That was one of the things that we were doing. But basically, I should say that really now, if you can combine that, the frequency domain and the time domain technique with broadband spectroscopy, then you can do more because, you know, you can have many colors, first of all, and then the spectra, you can start looking at the spectra of other stuff. And this is sort of becoming very interesting now because you can look more carefully at something like, you know, cytochrome-C oxidase, which is a molecule in the mitochondria, which is important for metabolism. So you can get molecular information about metabolism. Even just, but also just looking at water is actually quite useful. Okay, and so I won't say any more about that because I don't have any more examples of it, but I just want to look at that. So at the end, with these very simple techniques, then we can measure blood oxygen saturation, blood volume. We can measure these other molecules if we go to the broadband spectroscopy, and then we can also measure contrast agents that you put into the body, right? For like detecting breast tumors or something like that. Using either absorption or fluorescence, okay? So these are all things that you can do with the standard technique.
During COVID especially, we became aware of these things that they pinch on your finger and you can buy at home.
Yeah, so but that, I wanted to make a distinction about that. So that's a pulse oximeter. That measures oxygen saturation, arterial oxygen saturation, okay? Which, what we are measuring is the tissue oxygen saturation. So that's measuring sort of the oxygen coming in, which is useful, right? If it suddenly goes down to like 70, then it's good. But and it's also extremely simple, right? But it's not looking at the tissue; it's looking at what's coming in. But so yeah, so I don't want to cut it
But
down.
just basically because it's so superficial.
It's because of the trick that it uses to yeah.
Okay, you can explain it.
Yeah. It's not. It isn't superficial. It goes through the finger.
Right.
Yeah. So.
But I say it's actually a significantly different technique.
Well, it's spectroscopy using diffuse light, but I'll just say that we're measuring it of the tissue underneath the probe, and it's not just looking at the arterial. So one of my slides, right? So we have the oxygen's coming in through the arterial side, and it sort of goes to the capillaries and comes out the venous side. But we're measuring a macroscopic average over that vasculature, over a centimeter or millimeter. And this one is only measuring the arterial part. Okay. So that's a good question. Okay, so this is good. But we can do more. So this is more related to what I talked about and Dave talked about when he first came to Penn. And that is that you can look at the same, you can look at this light coming out, and basically you can look at the very fast fluctuations in time that it experiences. You can look at the correlation functions. So there's lots of different ways to look at it. You can look at it in time, you can look at it for the intensity autocorrelation function, which is the easiest thing to measure at some level, but you can also look at the field. And you can look at it spatially, or you can look at it at one speckle versus time. And the good thing about this signal is that it tells me something about the stuff that's moving, which is the blood. Okay? So, and this, so actually David Boas was my student many years ago. He sort of realized in a different way this DWS approach from a differential equation approach. Let me just say the main point is that just like we had the light fluence rate, or the photon concentration as diffusing through the medium, now if you look at the light correlation function, it also is diffusing through the medium, okay? And so it's also obeying the same diffusion equation almost as we've been using to understand the standard light signals. The only difference is that in the absorption term, there's also a term due to the motion of the scatterers, okay? And so typically in the measurements that one does is you would measure an autocorrelation function, and the decay of this autocorrelation function will be related to this mean square displacement of the scatterers that move, and you get a kind of a blood flow index, okay? And actually, I should just say that I spent a lot of time trying to convince people that it was consistent with other measurements of flow, okay? But I'm not going to tell you any of that. But so here's just an example. This Chao Zhou did this experiment. We were looking at brain injury in a pig model. And this is the correlation function of the living pig versus the dead pig. Okay, there's lots of ways to figure out that something's dead. I wouldn't recommend doing this. But this is like a 2 order of magnitude difference in the decay time. And I'll show you some measurements later where we're looking at functional activation. And then it's like a 10% change. Okay, but you can measure it. It's a strong signal if we're just going to look at the changes. Okay, so now what do we have? Okay, we have that we can measure flow. We have that we can measure blood oxygen saturation, blood volume, and all these other things.
And Arjun, what's moving in the dead pig?
It's Brownian motion. And in
It's
fact, if you look at the correlation function, it's different. Yeah. Okay, so now we can do more than with this information. And one thing that you can do, this is something that we started exploring all optically, is if you measure both the blood flow and the blood saturation, then you can measure oxygen metabolism, which is a potentially other useful biomarker. Okay. So I should say that good measurements of flow or good measurements of oxygenation are useful. They're good biometrics in their own right, biomarkers for injuries or for disease. But oxygen metabolism is qualitatively different. So again, this is just a very primitive way to understand this. So just imagine I have tissue, and the pulse oximeter measures the arterial saturation coming in, okay? So that depends on the oxygen saturation and the blood flow. Then the tissue takes that oxygen and does work. And so that's the metabolism. That's CMRO2, this is for cerebral metabolism. And then the leftover oxygen goes out, okay? So you can sort of write a simple equation that the cerebral oxygen metabolism depends on the saturations and the blood flow, okay? And you can make a few assumptions which aren't really very bad. And you can rearrange this. And basically you can show that, well, okay, why this metabolism is related to 2 things that I can measure, okay? And especially if I'm measuring relative changes in it, then a lot of the constants in that proportionality will just divide out. Turns out. Okay? So, so we showed this. This is a while back, of course, but Turget around did this. And so if you tap, so we wanted to show, well, we can, this idea is good and also make measurements using just optics through the brain. So, if you tap your finger like this, there's a piece of your motor cortex over here that's involved in that. And so the metabolism of that little region goes up, and when you're tapping it, and the blood flow going into that region goes up. If you did it with this one, there's a region over here, okay, that gets lit up. So we made a little probe, and we got 5 subjects who were healthy people. They were all bald, I have to say. But basically, then we put the probe, and you can put it in the wrong place, or you can put it in the right place. And actually, we had Mark Burnett was the surgeon, and yeah, there it is. And basically, we had trouble finding this thing, right? But he could just put his fingers on the head and just find it right. And so anyway, this is if you put it. So this is now. So what we did is in all of these things. It's you do is you have a period where you're resting, and then you do an activation, and then you stop. So this is sort of taking that data. So this is sort of before the tapping. This is during the tapping. That's after the tapping. So here you see there's nothing, or nothing. It's noisy, nothing. And so I'm plotting changes in cerebral blood flow, changes in oxy-deoxyhemoglobin. But that's because it's just like 1 centimeter off the right spot, okay? So if I go to the right spot, now this is now an average over 5 people. But basically, it really was huge. It was a pronounced signal. So this was a very happy day for us, or happy days. And so you can see the flow went up. That's the blue curve. You can see oxy goes up and deoxy goes down, right? And then also we can compute the metabolism. So we got numbers for how much does the metabolism go up locally when I tap my finger, which is very quantitative. It's very nice. And we did it non-invasively, transcranially at the bedside. Okay, so that's one other biomarker. I wanted to mention one more thing because I wanted to give an example about it. And that is if you can think about not just doing optics only, you can think about combining with other things that people measure. You can always think about doing multimodal imaging, and that can be very useful, especially with AI now probably. But basically here, if you just measure the pressure and the flow, okay, then you can learn something about tissue autoregulation, okay? So, and this is another potentially useful health biomarker. So let me just tell you a tiny bit about that. Okay, and so I should say this is like conventional wisdom, but actually it's debated, what I'll tell you a little bit, but the general thing is still correct. I mean, at least people would agree that the general thing is true, but there's little things that are wrong about it. But basically, so the conventional wisdom, so your brain tries to keep the flow the same, okay, if it can. So the flow is driven by what's called the cerebral perfusion pressure, which is like the difference between the mean arterial pressure and the pressure, it's called the intracranial pressure. It's just the pressure in your brain, okay? And so if you are, if your cerebral perfusion pressure is between, in some middle range, in some normal range, then no matter what it is, the brain, the arterioles can be dilated or constricted to try to keep the flow constant. And that's what your brain does. But if you're too low or you're too high, then actually what you'll find is that the flow will depend on the pressure, right? And so if the flow is following the pressure, that's kind of a bad sign, all right? If it's, that's a sign that the autoregulation could be disrupted. Okay, so that's a potentially useful thing to be able to look at if you have brain injured patients, okay, for example. Okay.
Can the probe, I got a little confused,
Yeah.
was the tapping just useful because it was known where that was activated?
Yeah.
But you do it all over
Well,
because,
so
is it all mapped? So you know
Well,
what you're
so,
looking for?
yeah, so there's a field in that, like MRI does it the most, right? Functional MRI, basically, so people have mapped out different regions of the head, so we knew that. So the thing with this was just to show we could do it with all optical techniques and, you know, and actually still to measure it is good. And again, even if you did the activation, well, I won't, you know, you're measuring different things with the MRI. The bulb is sort of sensitive to one of the either deoxy or oxy, I forget, but basically one of them through its T2. And so, you know, we're measuring quantitatively different things. That was what was good about it. Okay, so now I'm going to switch gears and tell you just about some things that we've done. Okay, and to kind of give you can, you know, what's gone well, what's not as well, so on. So we did spend a lot of time about breast cancer imaging. And so so this is actually, I've so far kind of described this problem as a monitoring problem, or maybe at the best of regional monitoring. So there's some spatial resolution, but it's really set by where your probe is, pretty much. But you can also do much more. Based on the diffusion equation, you can, if you make many measurements on the surface, you can set up an inverse problem to figure out what's the different optical properties at different volume elements within that inside that surface, you know, tomography, right? So, and that's challenging, and I'm going to just completely gloss over all the challenges, but let me just give you the idea of it, right? So if we think about those diffusive waves that I talked about in the beginning, so we can have a source, and it launches this diffusive wave into the medium. If it was homogeneous, it would just go straight through. If there's some heterogeneity, maybe the vasculature is different, so the blood concentration might be different somewhere, or something like that, then that will produce a scattering event, right? It's like scattering that we see in love so much. And then, so by measuring on the surface, essentially this kind of scattered wave, you can set up a problem, inverse problem to assign the optical properties of that region and of every region itself. Okay. So we, you know, not just us. I'm just giving you examples from my lab, but basically, you know, we spent a lot of time working on making sure we could do this well at the bench. Okay. And so, you know, here's one setup where we just had light sources on one side and the CCD on another side. And I think, you know, you could do it with CW. Usually we had a combination of frequency domain and CW. And, you know, you have a big block like that that's 6 centimeters thick, where you can have a tank of intralipid or milk and put in letters like pen. And it basically works. It worked. Okay, we could do it. This is a sort of intermediate time when we were doing it, trying to really see how well we could see things. So resolve things, and you know, if we could resolve in the middle and or the front and the back, things like that. So we sort of are convincing ourselves we can do this, and so then we tried to do it, really, in the clinic. So Regina Cho led this. So we basically got a needle biopsy table, and we basically set up an experiment where we had many, again, it was in a soft compression geometry, and we have many sources on one side, and then some detectors on this side, as well as a whole set of detectors on this side with a CCD camera. And so this is kind of how it looked, roughly speaking. And you know, it was we got a lot of data in a relatively short time, so we could do these things. And we did like 50 patients. I'm just going to show you a couple things about it. You know, basically so what's kind of cool, so we were able to resolve tumors that were, you know, certainly most of them were around 1 centimeter or so. Okay, there are some that are a little smaller, there are some that are bigger. But basically, we can see them, we can resolve them, and then remember, we can get a lot of information. It's not just like the attenuation of X-ray. or like X-ray absorption that would be sensitive to, or something like that. We can get information about how does the hemoglobin concentration change in local regions, how does the scattering. You can combine these and make an optical index. And basically we basically were able to use the endogenous properties to identify the lesions, and we actually showed, at least in 50 patients or so, and other people worked on this as well, that you can have a prediction about whether a lesion is cancerous or not cancerous. But the one big problem, I mean there are more than one big problem, but one big one was that the contrast is small. Okay, so I feel like this really can be a tool that would be used with another modality more effectively, okay, to be more for diagnosis. But the contrast is small, and so that led us to look at contrast agents, which I mentioned earlier. And so one contrast agent that's well known and FDA approved is something called indocyanine green. And this is, a molecule you can excite it at one wavelength and detect the fluorescence at another wavelength. So we sent in diffusive waves at one wavelength and detected fluorescent diffusive waves at another wavelength. It's kind of a more complicated problem. Before I just had one inverse problem, right? Now I saw I need to solve a problem for the excitation wave. So I have one inverse problem and then use that as a source, as information for the fluorescent diffusive wave. Okay? But the thing is, so we were able to do that. Again, it wasn't a lot of patients, but we did it in like 5 patients. And the way you do it is you first make your measurement before you inject this contrast agent, then you inject a bolus of contrast. It goes in, and then there's a period of 10 minutes where we do the fluorescence. We look for the fluorescence. And then we do a reconstruction. And the only thing, so this is just one patient, but basically the one thing I want to point out is that there is contrast in the other images, but it's like 1.3 to 1 or something. I mean, it's small. But when we just did this and we found that it was actually quite a large contrast for the ICG. So this is something where there could be potential for the optical technique if you can make contrast agents that are targeted. Okay? And so that's where I'll leave that for the imaging, the full imaging. I just want to say one other thing, which is that there's other really good problems and low-hanging opportunities for these techniques, but they're more monitoring or low-resolution imaging techniques. And the biggest one is like just looking at a cancer, like if you know where the tumor is, but you're trying to treat it, okay, then look at it during the treatment, okay? So if sometimes a woman might have a big tumor in a breast cancer tumor, and instead of just doing surgery right away, they don't want to do that. They want to first do neoadjuvant chemotherapy, okay? And so, but there are different drugs people use for neoadjuvant chemotherapy. And so some would work with certain people and maybe not work with other people, vice versa. And people don't really necessarily know why. And so what, Jeff and David, but this is a project that Bruce Tromberg initiated among many universities, is we basically looked at versus time longitudinally for like 6 months, right? But not continue, like in the before, then in the first week, 3 months, something like that. But basically looking at how is the tumor remodeling in terms of the oxygenation things that we can measure and water. And how does that correlate what we see with complete pathologic response before the surgery? And so this is promising, okay? So it's I think this is the lowest, this is maybe the area that we have the most impact right now in cancer, is in the cancer therapy monitoring. Okay, so let's see, I just want to make sure how much time am I? Okay, so now let me talk a little bit about brain, okay? And again, we've been doing a lot of different things. I'll just show you a couple things. But let me just again remind you about opportunities here, okay? So, the brain is really interesting to understand, I think. Everybody knows that. And hard to understand. So, but we're kind of, this is more like plumbing. It's not, there's some efforts now that I think are getting understanding, but this is still like, but if you think about like, if somebody is injured, sometimes, not even all the time, they might get something, a needle put in their brain so that they can monitor the oxygen, they can monitor the ICP, the intracranial pressure, things like that. And sometimes when you, so this is a very invasive thing, and you can actually induce strokes, okay? So there is an opportunity to have, for non-invasive in this context. The other sort of limiting thing is that, there's great MRI techniques and X-ray CT techniques that are out there. And, again, they're complementary sometimes in what they measure compared to optics, but basically they're good. But they're never going to be you're never going to do that at the bedside, right? You could just maybe do it once, maybe twice at the most. So if you want to have a management, if somebody's injured, or they've had some surgery and then they're in the neuro ICU, they could be in the neuro ICU for a few days, or 7 days. A lot of the bad things that happen afterwards, the surgery, right? Some tissue gets damaged. And so this gives you an opportunity, if you had a bedside monitor, that you can look at it continuously and see, are bad things happening? Should we make treatment? So that's sort of what we're thinking that the niche, one of the niches is. So we got together with Andy Kofke and Ram Balu, and they basically work in the neuro ICU at Penn. And so what we did is we basically looked at patients and that they were already looking at. Okay, so the patients that we looked at already had this bolt in their heads. Okay, and then depending on what the bolt was, it could measure oxygen at one point in the brain. What's the oxygen concentration there? There is actually kind of a measurement of blood flow that they can do at that local spot, having to do with thermal diffusion, but it's not that reliable, frankly. And they can measure the intracranial pressure, which is actually important, okay? And they measure, of course, all sorts of other things, like they would measure MAP, pulse rate, all sorts of other things. So what we did is we just said, all right, well, can we also just put our probe on the heads of these people? And so then we can look at how does the things that we measure, how do they correlate with what they're measuring, right? And how do they correlate with what we think is maybe an adverse event?
What's the structure of one of these quad lumen bolts? Is it a bundle of optical fibers that goes into the brain, or?
It's like a catheter. It's like a catheter with a bunch of needles or fiber. It could be there's no optical fiber, but people are just now trying to put optical fibers into them too. But these are just like a catheter, and there's a needle going down.
Sounds really
They're like 4 different
why,
needles.
Why is it called a bolt?
I think it's bolted on.
Okay.
Tap your brain,
Yeah.
and they tap your skull.
Yeah, it's okay, so what are the kinds of things you could see? Maybe you could see spikes in metabolism. These are the things I set you up for these because earlier, so we'll see some of these things. The impaired autoregulation and things like that. Okay, so just to remind you then, we have our probe there, and one of the things that we can measure is blood flow. Another one we can measure is oxygen extraction fraction or oxygen saturation. Another thing is this oxygen metabolism, okay? And we can look at this versus all the things that are being measured, right? So in practice, so this is like 4 out of 10 charts that would be for each patient. So this is a patient versus time. Notice the time is in hours. So we're monitoring for a long time. This is what I was saying, the value of the bedside. And so this particular patient, let me just say, so the top plot is blood flow changes relative to baseline. The second one is called oxygen extraction fraction, which is related to that oxygen, how much hemoglobin is oxygenated. Again, relative to baseline, then just MAP is mean arterial pressure, they're measuring that, and then this PbO2 is from that quad lumen, so it's oxygen in the brain. And so, in this case, this was a patient that came in and had an intracerebral hemorrhage. And they were there, and if you'll notice, like the MAP there is going from 100 to like 120. So they didn't like that. Because if you have too high pressure and you had a hemorrhagic stroke, maybe you'll have it again. Okay, so they changed the infusion of phenylephrine to try to lower the pressure to reduce the hemorrhagic risk. Anyway, so what you can see so that's what's happening to the pressure, and you can see we're getting these traces of stuff that's happening. So this is like super exciting to these doctors actually. And so I'm just going to show you some analysis of it. You can see that right when they changed right when the MAP was going up, then the flow really went up, right? And so then when they gave this drug, it started to shut down, right? But so you can start, so let's look at it. How does it varying over time? And this is sort of a summary of it. So this is time on this axis, and then I'm showing the oxygen metabolism, the blood flow, and then what's called that oxygen extraction fraction. Okay, and the main thing I want to just show is that sure, the metabolism and the flow both went up right away as soon as they changed this. As soon as they changed this, that they had this event, and then they went crashing down. But the metabolism actually went down slower than the flow, and so the oxygen extraction fraction went up, and all that means is that there was a mismatch between the oxygen delivery and the oxygen needs for the metabolism. And so this is kind of a useful thing for the doctors to know, that's not a good situation. Okay, so the next example just is connecting back to this autoregulation idea. And just remember the theme was that if the flow is following the pressure, that's bad. Something's not auto-regulating, okay? And so again, here's where we can look at flow and oxygen. That's the top graph. Here are 3 other graphs. One is the mean arterial pressure, one's the ICP, one's the PbO2. And essentially the doctors are changing this norepinephrine dose. It's all in a catheter. And they're changing it just to try to keep the pressure where they want it. And then what we did is we just looked at how does the flow look with versus pressure. And you see it's not correlated. So this is good. This patient is autoregulated. Okay. But then, here was another one. And, the only point I want to make is in this case, it was really easy to see that it was correlated, which is bad. Okay. So you have a well-defined thing that something is messed up. Okay, so that's just very crudely using the measurement of flow and the measurement of pressure. But if you make the measurements fast, then you can look at the waveforms. Okay, and so I won't go into this, but by looking at the waveform of the pressure and the flow and making a model of the vasculature, okay, simple model, and really the models are RC is the first model. Actually R is the first model, just the resistive thing. But basically you can use these waveforms and their values at your heart rate versus CW. And you can actually extract information about the intracranial pressure, which is very useful because if the intracranial pressure gets really high, that sort of squeezes down on all the vasculature and slows the flow and starves the brain. Okay, so by looking at it fast and doing an analysis of the waveforms, there's more you can do. There's a lot more. Here's another thing that I'm kind of excited about. It's just, we did it in just 2 patients so far, but basically, so there's this thing called endovascular, it's like a mechanical thrombectomy. It's called mechanical thrombectomy. And so basically, Chris Favilla, who's the our doctor, collaborator, he basically threads a little thing, a catheter, something up through your, if you have a blockage, in one of your MCA or ICA, your feeding arteries, they thread this thing up and it actually just grabs the blockage and pulls it out, okay? And so this is something, again, where we're in a situation where we want to know, did the flow turn on? I mean, you can look at the flow in the main arteries, but you might want to know how is it in the peripheral arteries and things like this. And then how is it, well, ultimately, so the first step is to show we can detect these things. Ultimately, we want to learn about what these signals should look like so that we can minimize secondary injuries like that. Anyway, so what we did is we put a probe, we put the probe on the forehead. So that's why we did the ICA, because it affects, the forehead's kind of close to it. But you can look at the, and so these are just, don't worry about the details. It's, again, we had a short separation and a long separation. The short separation lets us look at the scalp and skull. Long separation lets us look at the brain, the cortical regions. And we just could compare like the side, how's the flow change after the thrombectomy on the side that had it compared to the other side, things like that. And yeah, so this is angiography showing the effect. And here's our data. Okay, so, again, this is our first try about it, but you can see that, so this is time, and relative blood flow is the red one. And the black one is the short separation, and the red one is the long separation. So the red one's looking at the brain. And you can see that this is where the recanalization occurred, big spike in the flow, and then it sort of stabilizes at a higher value. And also, you can see the mean arterial pressure is changing, so it's, and the flow staying about the same, so it's autoregulating, so that's good. If you looked at the contralateral side, maybe there was a slight increase, maybe because there was some feeder vasculature on the other side. But anyway, so this was encouraging for us and encouraging for Chris. And that, there's also people that are looking at I just wanted to mention one thing, Joe Kolber and others, but Joe especially, is you can look at the resting state networks of the brain by looking at the correlations. You measure all, here you now need a whole brain helmet. But basically, by looking at the correlations in the oxy and deoxyhemoglobin, or even the flow, or even the metabolism, you can find out what are the resting state networks. And then you can potentially, again, if there's injuries, if people have injuries, you can look at, is the resting state network messed up? We've been using it in heart bypass surgery, mainly with pigs. And then during ECMO, right? So these are people that are on heart-lung machine. They're really, they're in danger of dying. But you're basically making their flow. You're oxygenating the blood, pouring it through, and you can look at how is the brain responding to that. So how am I doing, Dave?
It's 4 minutes to 5.
All
There's
right,
a clock
I'll just
right
stop.
behind you.
I wanted to just say something about the placenta.
Okay.
I did want to say one more thing. Sorry. So what I try to do is just show you what we're doing. Tell you a little bit about what the ideas are and then what we're doing. But I want to say that there's actually been a lot of technical innovations. And I think it's going to be a spectacular growth soon. And the main one, well, one of the main ones, is that pretty much all of my measurements, we have just a few fibers for the detection. And even for the flow one, we had these APDs that were expensive, okay, to do the correlation measurements. But now you can detect, you can use multimode fibers, you can use cameras. There's a whole effort now to just parallelize like crazy out of the detection. So I think that's going to make a huge difference in terms of the speed and the distance that you can probe into the brain. Okay, the signal noise is going to be great. The other thing is that there's interferometric and other kinds of gating methods, which is related to the first paper that we wrote many years ago, to select the photon paths. And that's another way that, because even though I've completely glossed over it, it is a big pain in the neck that the scalp and the skull are between, are above the brain, okay? Because you have to disentangle the scalp and the skull signals from the brain signals. And so by doing gating of different kinds, you can actually improve the fidelity of your information. And the other thing is people are looking at not just in the near infrared, people are looking in the shortwave infrared, which is also quite interesting. It has different amount of scattering and things like that. So I'll just stop there and remind you that I didn't actually do anything.
So we have time for some questions. David?
So all of your probes are going from the sort of outside of the skull in.
For the brain.
Yeah. Why not go up into the sinuses? Because then you have access to the deep skull. I mean, so the deep brain, the old brain.
That's a good idea. I haven't heard of anybody doing that right now, but I wouldn't be. I've heard of people doing the captive, the bolt thing.
Yeah.
That's another way to get into the brain. But yeah, maybe that might be good. The cortical region is a good region to look at, and so you're looking at a different region, but that's good. I don't know. Why not?
Right?
Hi. The dynamical measurements are very sensitive to all kind of motions, heartbeat. How are you dealing with that?
Well,
Do
so
you have a solution for that?
So the waveforms. So when you make it really fast, you can just resolve all the heartbeat. You can even resolve the structure in the heartbeat, and that turns out to be useful. Okay, but I will not deny that motional artifacts are a big pain. And so, what do? So most of the time the data is good. Like say these people that are sitting in the neuro ICU. Most of the time it's good, but they're moving, and and the correlation functions are messed up. The data is messed up. But so you have to look at the data and filter it. So maybe we can automate. Well, we're sort of automating it more, but still it's humans. So I don't want to minimize that issue. It's important.
Paul.
Can you combine this with other techniques like ultrasound,
Yeah.
for instance, and then just locally probe?
Yeah.
Use
So
the ultrasound.
what I wanted to show you
There you go.
is that for this placenta measurement, the placenta was so, it's much deeper. It's worse than the brain, worse than the cortex. But basically, and also it's layered the tissues, right? There's adipose tissue, muscle. So we combined it. We made one instrument using a commercial ultrasound and optical. And so then we can use the ultrasound for the structural information to constrain the optical inverse problem.
No, but I was thinking of actually focusing on a particular spot, sweeping microwaves, so you're jiggling it and detecting where you are by the fact that I'm jiggling this spot.
You can,
inside.
so that you can do that, and there's a guy, the French,
Oh,
not Fink actually, but it's Baccara, Claude Baccara, I don't know. He did a lot of that. He did some of that, but also it's photoacoustic. I mean, in a way, this isn't the same thing as you're saying, but photoacoustic spectroscopy basically it sends in the light pulse, and that where it gets absorbed, it makes a sound wave, basically. And then they have the acoustic detectors, and so you can get a better resolution from the sound part, but you get a little bit more functional specificity from the optical excitation. So there's some things like that, but the thing that you're just mentioning about focusing something and shaking it, you can do that, and people did some stuff like that. Yeah. I don't know if people have done it except to demonstrate it. I don't think they've used it to do something. I mean, it's a trade-off for me about what I want to accomplish. Mila?
Other questions? Yeah.
Okay, so just piecing together what you said and looking at this slide.
Yeah.
Okay, so you're constraining kind of the inverse problem using the structural information you get from the ultrasound. How much detail can you get with like placenta,
Yeah.
hemodynamic
No. So this one, the main constraint is the layers. So here's what we do. It's not even it's an inverse problem, but it's a really simple one because they just have you know, layer 1, layer 2, layer 3. And I'm saying, I know that, but I do know the dimensions of them, but I'm saying that they're homogeneous when I do the inverse. But then, you know, if you do it versus wavelength, you can get, what's the property of the placenta? How's that changing?
So you get kind of like bulk properties of the whole placenta. You're not seeing like kind
Well,
of.
under the placenta underneath the probe. So for example, we had this experiment where the woman would, hyperoxia, she would breathe more oxygen. And then you can see the oxygen concentration in the placenta before and then during the oxygen and then down, right?
So cool.
And what we found is that this response, if it wasn't good, then it was correlated with it was correlated, you know, the p-value is 0.02 or something, but basically it was correlated with adverse pregnancy outcome. And we did these things in the doctor's office.
And then you're kind of thinking that the oxygen isn't diffusing well to the
Basically.
baby.
Yeah,
essentially.
that's that's the working. I mean, there's a big effort, or there was a big effort, I don't know if it'll still go, but there was a big NIH funding for understanding placenta recently. This is what we got funded for through, but because it's kind of an amazing organ, right? Because it's coupling these two living things, yeah, and so, but so I feel like I'm a plumber. I really, but still, plumbing is good.
Any other questions? Okay, let's thank Arjun again.
Thank you.